focus on the different introductions. So, may I just ask my colleagues to just put the slides in presentation mode because we see still the welcome one. So we will have, first of all, a more general and umbrella introduction on the topic of research in the field of prevention from Ande Carvalho, from the International Agency for Research on Cancer. Then we'll focus on the Prophet project on the personalized prevention, looking towards a strategic research and innovation agenda with Stefania Boccia from the Università Cattolica del Sacro Cuore. Then we'll go to the Transforming Health and Care Systems partnership, where indeed we'll work about implementation or prevention approach for sustainable health and care systems. So we're going to have a really nice focus on what's been the latest activities on the topic. And then for the second part, let's say, we're going to go first to the Joint Action Prevent NCDs with a double presentation from Knut Tingelklepp, scientific coordinator of the joint action, and Arfin Helve, leader of the work package on policy measures, regulation, and taxation. So we're going to have a little bit of a focus on that as well. Last but not least, we're also going to have the JANE2 joint action. So we're going to go to the healthcare professional side, let's say, looking at the implementation of effective personalized prevention strategies to combat cancer. So cancer-focused presentation by Delia Nicoar from the Oncology Institute in Cluj, Napoca, Dr. Ion Kirikuta. So without any further ado, I think we have more than 100 people present to today's meeting, and I will be pleased to give the floor to the first introductory presentation, let's say, to Ande Carvalho, who I'm asked to kindly see if he can put up his lights. There you go. Perfect. So Ande is Deputy Head of the Prevention Early Detection Branch in the International Agency for Research on Cancer of the WHO. And indeed, it will open today's discussion with a bit of an umbrella presentation on the topic of prevention and focus on cancer. So Ande, the floor is yours.
Thank you so much. And thank you so much also for this kind invitation to be here in the event. I represent our director, Elizabeth Vaidepais, and the International Agency for Research on Cancer. I'm going to talk about the challenge of implementing cancer prevention programs, but I guess, in different levels, all NECDs kind of struggle with the same issues or challenges, if you will. Right, just a recap how, the IARC correlates with the WHO main organization headquarters, right? We are specialized agents for research on cancer prevention, mainly, right, where we try to get evidence base for cancer prevention control programs. And with that information and other information as well, WHO translates these science evidence in policies and guidelines. Right. Just making a case for the cancer burden, right? We know that from 22 up to 2045, we're going to have more than 20% increase in the cancer incidence in Europe. We know that there is a huge potential for primary prevention. When we talk about cancer, that varies. We have some cancers that's preventable from 70 to 100% of the case. When we talk about cervical cancer, is 100%, or cancer 90, lung cancer 90%. We have some cancers that are prevented from, potentially 25 to 74%, and some that are the part that's primary preventable is less than 25%. We also know very much nowadays what are the lifestyle, environmental risk, or risk factors that when your exposure increases that risk, and so what can be preventable. And overall, we have that 4% of the cancers are preventable, right? When we think about, the economic case for investing in prevention in cancer, we know that the overall impact on cancer in Europe is estimated to exceed 100 billion every year in direct costs for the system. And there is a high return on investment in prevention for cancers. If you implement the WHO Best Buy for no communicable disease prevention, for every dollar that you invest, you're going to get $7 in economic benefits. Reducing tobacco use brings also a little bit over $7 for every dollar invested. And when we talk about reducing harmful alcohol use, this will be $8.3, for every dollar invested. So in short, prevention is not just cost effective, but in many cases it's cost saving. If we know that prevention, is better than use the cure, why still most investments and most of the advances and implementations go for treatment, in cancer and not for prevention? When you try to understand a little bit of what is the issues behind it, the first one is the publication pathway, right? Usually takes 17 years to turn 14% of the original research to benefit the patient care. So we have a big gap known to do that we try to cover most of the times, right? And this is pretty much the case in cancer with implementation research, right? That we're going to try to bridge this gap by getting evidence-based findings into practice in a timely manner. And it's specifically important for developing countries facing a shortage of resources and challenges in healthcare system. If we go to the spectrum of when implementation research should be done, when we think about the innovation and the research gradient, right? The proof of concept, it is safe and does it works, and the proof of implementation, how it works in a real world setting, and the informing scaling up, health system integration, and sustainability, we can see that the focus on the implementation changes in terms of importance. If at innovation point implementation is not relevant, but when you move forward, towards the proof of implementation, how does it work in real world settings, implementation is relevant but not considered, right? So we are missing sometimes early, integration or implementation. But when we move to health system integration and sustainability, implementation is the primary focus, right? At IARC, we try to put implementation research in this part, but not, we need to do way more in global, in Europe setting about that part of implementation research. So implementation research became part of the first emergence priority at first in the medium-term strategy from 21 to 25, and going to be renewed as an important part of IARC, right? So putting that, where are we in terms of prevention research landscape in Europe, right? And when we talk about way more be done in treatment than in prevention and in cure, this is what is reflected in terms of funding. Only 14% of the European cancer research papers has focused on prevention research, and only 70% of those papers, right? We're talking about 7% under this, the 14% are categorized as implementation research. Not only that we do too few research papers on prevention, but even less on implementation research. Only 16% of all European cancer research funders show interest in prevention research, and less than 4% of them show interest on primary prevention. And this is how it maps out, right? Investment funders, of number of funders supporting cancer prevention is more likely to be on high developed index countries. So you see the North Hemisphere with more of the funders supporting cancer prevention, almost none in Africa, way less in Latin America and in Asia overall. Right? So Europe, on that sense, is on the top tier. But when we see what that means, even for the top tier, right, when you talk about all types of funder, how much they put in primary prevention, the overall is 16. But government organizations and international organizations is investing about 30% of their grant funds on prevention. But that goes less and less when you talk about not-for-profit, for-profit, or research facilities. So the investment kind of varies depending on the source of the funder. And in average, we have 16%, of the funds in prevention in Europe. This trend is going up, right? So we see a good increase, in terms of number of funders from 60, to almost 160 from 2008 to 2021. And also the number of publications on the field have more than double in that time. But also we can see that, even though the trend is upwards, was way faster in the first part of this timeline than is doing now, right? So we need to make sure that this trend continues up, but also that gets a little bit more speed, or the slope of the curve gets better than it is, consider the scenario. It's also important to talk, how much does the country put in prevention regarding their health expenditure, right? That's relatively low. Even though when we compare 2019 to 2021, there is some increase in most of the countries have been increased. This is the difference between the bar and the dot, the losange dot. Some countries, unfortunately, decreased the investment, like Slovakia Republic, and some countries just kept the same, but most of the countries are investing more. But this is still a max of 10% of all the health infrastructure invest in prevention. And that tells, how much you are spending in treatment versus in prevention overall. 90% of the money that goes for health expenditure is still invested in cure or treatment. And how that reflects all this variance on how much you put in prevention, and how the population, take into that prevention, we see in Europe very high differences in terms of, exposure for risk factors or screening coverage. When we talk about control, Ireland and UK has a tobacco control score of over 80%, while Bulgaria and Switzerland has this tobacco control score under 45%. When we talk about obesity, we vary from Italy with around 70% to Malta, around 29% of obesity in the population. Alcohol consumption per capita, around 12 liters per year in Latvia, around 1 in Turkey. And then we go for vaccination uptake, countries with over 90% of uptake for HPV vaccine, and then Romania and Poland with less than 20%. Same thing for screening coverage. So we see that even though, we are talking about Europe or Europe EU plus, the variance is quite high and investment is still relatively low. What can we do, and what are the success stories when we try to bring, research into action, as this is what we're talking about, right? How we can get more investment in terms of research, but when we see the fund, the intervention that works, how can we transform that in policy, and how that relates to more investment from the health authorities into the health system? We see that this have been the case to some interventions. So HPV vaccination has scaled up in many EU states following trials proving its efficacy, and new evidence in colorectal screening, led to EU to update screening recommendations in 2022. Right. So this showed that with the right political will and the public communication, research and promotion of behavior changes can drive policy and can drive change in the health system. Right. We also know that there are some initiatives to improve that in terms of improvement in investment in research and investment implementation. European Beat Cancer Plan had earmarked 4 billion for action against cancer, including prevention. Calls have been made double the European cancer research budget by 2030 with a major boost in prevention research. Right, and you have EU fund initiatives like Horizon Europe and Mission on Cancer and the Prophet Project that we're going to hear more about during this event, that's trying to create a research agenda to better coordinate and scale up prevention investments. So we do have some things coming into the Eurozone that's closing the gap in the EU. But once also, to bridge the gap, we need to think about how we're going to do to build capacity in the health system for the implementation, right? Part of this is that we prove that some implementation works in real life. We make these become policies, but we need to implement in the health system. And that brings another layer of challenges when we talk about implementing prevention programs, right? This is about how our health system is ready to implement cancer screening prevention, scaling that requires health system to be prepared and keep how our workforce and training ready for the scaling up, how we're going to need to train professionals. We're going to need eventually to hire more public health professionals so we can do a proper scaling up of any intervention in prevention. We need to integrate prevention targets in healthcare providers' performance indicators so we can monitor, we can not only incentivize, but we can also monitor and measure the impact of it. How are we going to facilitate capacity building by supporting knowledge exchange? How can we share best practices from countries that have successfully integrated preventions into primary care or into the health system? We also need to think about the infrastructure and data system, how we're going to we know that sustainable infrastructure is critical with the proper linkage between the health databases with outcome data so we can measure it. How we're going to do the cross-sectional collaboration, the health system capacity for prevention of extend beyond the health sector. How we're going to be, reducing the tobacco or improving diets involve sectors like education, financing, taxation, urban planning, and others. How can we do this cross-sectional collaboration so we can implement more into their life? How we're going to do learning health system, right? The goal to make health system as a learning systems for prevention by continuous using data and research to promote improvements. So going to the end of my presentation, right? We know that overall there is strong EU national frameworks in terms of policies, in terms of investment, but they're uneven in terms of implementation considering different countries. The overall trends in prevention are better, in terms of we're doing better in preventing diseases, or exposure to risk factors when you talk about cancer, and also in terms of investment in research, but it's low, it's still uneven, and it's still overall lower than what we can do overall. We need to think about a multi-sector approach environment, lifestyle, healthcare, education. Policy focused cancer research agenda should be a major focus on it, and thinking again that preventable fraction of up 40%, when we fully implement all that European Code Against Cancer promotes, could avert hundreds of thousands of cancer. We need to bring back that effective and sustainable implementation of NCD prevention requires a holistic, integrated approach that brings together research, implementation of evidence-based intervention, policy action, financing, stakeholder engagement, workforce development, behavior change, and data-driven monitoring. And that's kind of a big challenge, how we're going to put all together to kind of really bring the gap between findings in research through real world impact. What's the way move forward? We need to increase and coordinate fundings for prevention research. We need to increase investments and capacity building in research in implementation science. We need to translate evidence into policy through implementation support. We need to create platforms for research and policymakers to interact, like the JRC, the Knowledge Center on Cancer. We need to build capacity for implementation within the health system to have that integration. We need to think how we can sustain political commitment and treat prevention as an investment and not as a cost, right? We saw how much return on investment we can have, how many lives we can save, right? And we need to monitor this policy uptake as a key to make sure that what we know in theory gets applied in practice and get impact in terms of improve lives and saving lives. With that, I would again thank for this kind invitation for the participation. Thank you.
Thanks a lot, Andre, for your great introduction presentation. You have indeed touched several points that I think we'll take up also during the other presentation. Indeed, the need for, of course, better communication, coordination, like actions like Profit, where we're going to go in just a second. I know that you have to leave in about 20 minutes, and while we're going to have a Q&A at the end of the session, I just want to, if it's okay with you, to pick up one quick question that I see in the chat early on, referring to your slide where we were showing that 14% of research indeed takes 17 years to turn into benefits for patients. And a colleague from the audience asked how could AI reduce this 17-year long process? I think it's the mandatory AI questions that everyone gets these days. So you're the first one to get it.
Okay. So this is a good question, right? And I think we're integrating more and more AI into not our only lives, but in our research setting. And I think we need to use that wisely, and proper. So that gap means, when you have an idea to your publication, taking in consideration that many articles or publications will have negative results or not, advanced in terms of they were going to advance knowledge but not changing practice, right? The whole process really takes too long. One way to short it is implementation research. The other one is see how artificial intelligence give us, a quicker way to publish, a quicker way to move that in terms of strategically, moving upwards, kind of, each step that we have, each hurdle that we have in terms of getting published, in terms of how that gets disseminated so more people can validate it, that results, meaning that has, in different settings can be replicated. That's what makes things to get to the real world. So I don't think there is a clear roadmap how to do that using artificial intelligence, as we are still in the early stage of how we do that in research, but I see a huge potential on it.
Thanks a lot, Ande. And indeed, I know that you will have to leave, so I will move to the next presentation. But I see also some other questions in the chat, so I maybe ask you kindly if to have a look directly there. If you want to drop your contacts or respond directly, that's also something I invite all speakers to do while we go ahead to the different presentation. But now, indeed, thanking again, Ander Carvalho. We go ahead to the second presentation of today. In this case, it's about a project that we've heard they nominated a little bit before from Ander. In this case, we're going to go to Stefania Boccia, professor at the Università Cattolica del Sacro Cuore and coordinator of the Prophet project. And we're going to go indeed with Stefania with a focus on personalized prevention and what Prophet is doing towards strategic research and innovation agenda. Stefania, the floor is yours.
Thank you. Thank you very much. Can you hear me?
Very well.
Okay, great. So I will start immediately telling you just a couple of words of what the Prophet is about. So Prophet is a coordinating and support action funded under the umbrella of the International Consortium of Personalized Medicine that has the overall objective to co-create with stakeholders a personalized prevention roadmap. So we are now already in the third year of life of the project, and that is supposed to basically finish by September of the next year. We did start our work. We are 18 partners actually, with a working definition of what we mean for personalized prevention that we also published on the European Journal of Cancer Prevention. So Prophet is not only about cancer, okay? It's about personalized prevention of chronic diseases. And that's why we defined at the beginning of the project, as you can read in the brackets, personalized prevention as a set of action that can basically integrate the traditional way in which we do prevention today by targeting different action according to the traits of population defined according to risk factors. Risk factors that include not only lifestyle, environmental factors, but also inherited factors like genetic, but in general we call biomarkers, okay? Because some modification in the genomes can be acquired over the lifetime. Let's think about epigenetics, but also other omic signature like proteomics, metabolomics. So that's why basically we talk only about biomarkers, basically. So the integration of all this information together in principle can lead to a better stratification of the population and the patients when we talk about tertiary prevention that ideally can be target of different actions, different preventive actions that can be more effective and maybe also more efficient. In order to develop this strategic research and innovation agenda, that is basically the overall goal of Prophet, we provided, basically we use the methodology, okay, quite a stepwise methodology. So we started with a mapping exercise on basic and translational science in personalized prevention, then policy development, regulation and market access, and citizen and patient involvement, all mapping exercise. Then we moved to an assessment phase where we developed a framework, the Prophet framework that I'm going to tell you just very quickly. And then we're now in the building phase, the one that I will tell you more in detail, which is about releasing the first version of the strategic research and innovation agenda and having a public consultation, and then starting with the educational efforts towards policymakers, health professionals, but also citizens and patients. So the first year of the life of Prophet, we had a large mapping exercise. If you want to have an idea of what we did, you can use your mobile phone with a QR code, and you will be accessed to a website where you can download all the results in a concise way of all the mapping exercise according to the 4 major themes. But just to give you an idea, because now it's already 1 year after we finish all this mapping exercise, that is the basic fundamental part to develop the SRIA. we also publish some papers. So just to give an idea of some of the papers, okay? It's not all the papers published. So some of the mapping exercises have been published. One of these is a mapping of all the landscape of personalized preventive approach for non-communicable diseases. And then another review about the assessment reports of genetic and genomic tests that reveals all the dimensions used to define clinical utility. That is quite scattering in the literature. And then we publish, again, a scoping review about all the engagement strategies of patients and the public in personalized prevention in Europe using genomic information. So these 3 papers are very much focused on genetic and genomic, but the others are ongoing. So you will see some hopefully in the coming months. And this instead is a snapshot of only some of the papers about the mapping exercise on regulation and market access and policy developments. So about all the direct-to-consumer genetic testing, about the state of the art and barriers for the adoption of personalized prevention in Europe and beyond, and also about the secondary use data. Okay, in the context of profit, so before I move to the strategic research and innovation agenda, I want to tell you that we did develop our idea of how to use also the health impact assessment framework to appraise the health impact, taking into account the consideration of stakeholders, but also very much the equity aspects of access to personalized preventive interventions and tests, with a very specific exercise on a case study about the use of BRCA test that is not, unfortunately, that much widespread in some European countries and also in Italy, where basically you can see on the right the phases of the health impact assessment that is used very much beyond healthcare as a framework itself, but we did try to use in the context of profit also to apprise the health impact, the health outcome impact of the use of genetic and genomic application, because the BRCA genetic testing in Italy is definitely, let's say, underused, especially for testing family members of positive test subjects. We discussed a lot with different stakeholders about the relevance of making this health impact assessment that has been done for the very first time in this context of genetic testing in the literature. And just to give you just a snapshot picture of the results that revealed a very, important underuse and inefficient, let's say, use of resources today, because by using in a very homogeneous manner the test among family members of positive subjects, we can basically avoid a large proportion of cancers, ovarian and breast cancer, by 34%, and also deaths with and this is very much cost saving. So we are going to publish these results in an extensive manner, hopefully in the coming months. Okay, so I go back for a second because we did a lot of work in the profit and context of profit project together with all the partners. But I want to remind that the roadmap to personalized prevention that builds on the mapping, that builds on the case study of use of health impact assessment, it's something that has been foreseen in the European Binding Cancer Plan since the publication of the EBCP. As you can see, the strategic research and innovation agenda on personalized prevention should also incorporate a roadmap. And that's why I will show you in a second what we are going to publish. This is only the first version of the strategic research and innovation agenda of personalized prevention that has been delivered to the European Commission a few months ago. And it is not publicly available yet, but it will be very, very soon. So you can see how the table of contents has been developed. This is a picture that we had in Karolinska Institute, where we met before rushing to the final version of this first draft of the SRIA. There is a long part of background and methodology where we want to explain how we build this SRIA. And then the SRIA reports 10 different challenges for development and implementation of personalized prevention, where we also formulate in the challenge number 3 what we mean for the PROPHET framework, where, as I told you before, a large part is devoted to the use of health impact assessment exercise to forecast the impact of the introduction of personalized preventive strategy in the healthcare system, where we did our exercise on BRCA testing. So this draft of the SRIA, okay, so this is a more detailed picture of the challenges as a structure. So you can see in each challenge, you will see when it will be published open, that for each challenge we have a sort of reflection on the status, on the gaps, on the priorities and implementation and consideration. So each challenge has this structure, like 2 pages each, in order to focus on what is the gap today and how we want to, or how we wish, I mean, in our vision, to overcome these barriers. So the roadmap, the EBCP asked to make not only a SRIA, but a roadmap. So along with the SRIA, there is a detailed roadmap so that for each challenge, we reported the goal, the action, the obstacle for implementation of the specific challenge and the specific action, the outcome, tangible outcome, who is responsible for the action, whether there are other initiatives with the same objective, where we think that funding source should come from in order to implement the goal, European, national, whatever, and the output indicators. So this is overall the structure of the SRIA and the roadmap. Where we are now, and I'm finishing my presentation, we are now launching a public consultation of this SRIA and the roadmap. So you will receive, hopefully, those participating to this event can be added to a mailing list so that you can receive the link to the public consultation, because now we're in the middle of finalizing the final stakeholder consultation, and then we launch the open consultation to everybody in the month of June. Because by October we have to deliver to the European Commission the final version of the SRIA and the roadmap, and to present not only on our website, where I suggest you, if you want to go and to register to our newsletter, and yeah, if you want to also be updated on the activity, you can go on the LinkedIn. But we are going now in the last year of the life of the project, where not only the SRIA and the roadmap will be presented, but there are also other initiatives. This is led by the European Patient Forum, which is a partner of our project. You can register to this event for free if you go on this on the website of the APF. But as I told you, we are going to present the final version of the SRIA. Firstly, in Amsterdam, if you want to register, this is free. On our website will be delivered this information. And also during the European Public Health Congress in Helsinki in November, we have a dedicated workshop led by UFA, but also by Active Citizenship and Catholic University. We have an open session where the SRIA will be presented. So thank you very much for the attention, and I hope you to see soon in person in all these events. Thank you very much.
Thanks a lot, Stefania. Great overview indeed, building exactly on what Ander was saying. So showing how through the roadmap to the SRIA, you're working on organizing, let's say, very clearly how to respond to the challenges related to prevention in this very structured and co-created way, I would say, which is what you've done so far, and what I understand it's gonna come up even more in the coming months. So of course, I also invite any colleagues, if they want to share the links to the PROPHET website and to all the different registrations opportunities that you share, to do so in the chat. I do have maybe just one quick question that's coming from the chat, Stefania, as we are very much on time. I see a question related to personalized prevention and how strongly can we expect PROPHET to act so that gut microbiome analysis can become a routine screening across your countries? Is this something that it's indeed fitting in what you're going to do? And if yes, if you can just give us a flash response to that.
Thank you very much, Michele. Yes, I was reading this question, so we didn't go in through that specific topic. That instead, I hope that Delia will be telling something later in Jane 2. So in another project, we will have a dedicated mapping about the use of microbiome analysis in targeting personalized prevention. But in Prophet, as you have seen, what has been asked to us is to develop a framework, to develop a SRIA, then can be used across the next, let's say, decade to evaluate the personalized preventive approach against a specific framework. So we worked more about the methodology for implementation. We did make some exercise, some case study about some specific research question, and the microbiome was not in that specific case studies, but of course it is a sort of modifiable risk factors, so it is definitely a very interesting aspect to take into account for personalized prevention, in the context of personalized prevention. So thank you for the question.
Thanks, and thanks a lot, Stefania, for the further clarification. And indeed, maybe we're going to touch a little bit more on these in the Jane's presentation afterwards. But as we are now fully on time, I will go to the third presentation of today, where we actually a little bit sort of zooming out to the more even general health systems level and focusing on indeed what's needed to partner up for transforming health and care systems. And it's my pleasure to give the floor to Laura Motta from the Università Cattolica del Sacro Cuore and part of the THCS coordinating team, who's gonna focus her intervention on innovation related to prevention and what the THCS has been doing about that. So, Laura, the floor is yours.
Thank you very much. I hope that you can hear me and you can just see the slides.
Perfectly.
Okay, great. Okay, just a quick introduction on what is the European Partnership on Transforming Health and Care System. It is one of the European partnership funded under the Horizon Europe program, in particular under Pillar 2, Cluster Health. The partnership is coordinated by the Italian Ministry of Health. It started in January 2023 and it will last 7 years. It is made of a large consortium, of course, as most of the partnership. We are 64 partners from 23 member states, including also 9 regions, with a total budget of more than 300 million euro, and the contribution from the European Commission amounting at the 30% of the total of the cost. Of course, the partnership started in 2023, but the preparatory work started much before. The THCS is actually is coming from other initiatives that were living before the Horizon Europe program, in particularly the CSA to Reach, which provided part of the strategic research and innovation agenda that was then incorporated in the THCS strategic research and innovation agenda. But also other initiatives collaborated to that, in particular the AAL program, the JPI More Years Better Life, and the European Innovation Partnership on Active and Healthy Agency. The Strategic Research Innovation Agenda for THCS states that our main goal is to contribute to the transformation of health and care systems towards more efficient, sustainable, resilient, inclusive, innovative, and high-quality people-centered health and care systems, which is a very ambitious and very large goal, of course. In doing that, we want to touch 7 main thematic areas, including the optimization of care integration of services, the health and care systems financing, the accessibility and equalities, and the appropriate use of technologies. Also, the people empowerment and self-management is a key thematic areas, and also the integration of prevention strategies that we will talk today about. And of course, we will also deal with health and care system preparation to emergency threats. In tackling these thematic areas, we know that we need to also address all what we call the building blocks of the health and care systems, namely the health workforce. They need to do always reforms and policies involving people and users. We need to deal always with the digitalization of health and care services. And we needed to measure quality and safety with trying to identify common standards. It is important always to tackle and measure the dimension of the efficiency and sustainability of innovations. We aim, of course, to address the needs of researchers and to support them to be more engaged in collaborative research. We wanted to support health and care authorities and policymakers in making the best use of research results for decision making and also to plan efficient investments. And of course, we want to support health and care providers and professionals to implement innovative solutions. The work of THCS is made around three main work streams. The first one is filling the knowledge gaps, meaning that we know that we need to understand still what are the problems and priorities definition. We still learn from existing practices, so we can learn a lot from what is already existing before implement new strategies. The second was streams in implementation and transfer. And in particular, we wanted to, through our funding pillar, we will see it afterwards, we want to test and validate solutions. And of course, we wanted to boost health and care systems with actions in the field of capacity building to strengthen ecosystems and also in policy update. This is the main structures of THCS. We have, of course, a pillar 0, which is the program management. Under the pillar 1 is focused on science innovation into policy and practice. Pillar 2 is focused on a research and innovation funding, which is where most of the resources are concentrated in THCS. And Pillar 3 is the one dedicated to support transferability and strengthening ecosystems. What we have done since the start of the partnership. Under Pillar 0, we work, of course, to set up the governance. And in addition to the, I would say, the management structures, which are the General Assembly Strategic Board, we, of course, built the advisory board, which is important for us to receive information and also advice for DJ transitional calls. We are establishing national mirror groups to reflect the different structures of health and care systems in different member states and regions. And we are also building the ambassador network to try to strongly connect with other initiatives at European international levels. So, of course, we have developed our communication and dissemination strategies, which include also the organization of an annual conference done in 2023 and 2024 in Brussels. We are currently trying to start to update the roadmap and the strategic research and innovation agenda to reflect all the activities that we have done in these 2 years. And of course, as said, we wanted also, like we are doing today with this workshop, to establish synergies with other European partnerships and other European initiatives. Pillar 1 had very intense activities through survey and desk reviews. They worked on gaps and research and innovation priorities and needs to advance research and innovation capacity building for the transformation of health and care system. This was done by Work Package 4, which is also worked on the development of the THCS transferability and implementation framework. The framework is was built considering all the framework already existent for the implementation and transferability of practices and is now public available. We are now working to create an online handbook that will be integrated in the future in the Knowledge Hub. Work Package 5 is currently working on the tools for translating evidence in policy, and they are also preparing some masterclass that will be launched at the end of 2025 to be organized in 2026. Before moving to Pillar 2, we wanted to present a little bit the activities done by Pillar 3, boosting health and care systems. Work Package 9 worked a lot on the ecosystem-wide approach, trying to define what is an ecosystem, what are the currently ecosystems in Europe, and of course, what are the main aspects, the driver to develop ecosystems in health and care. Work Package 10 is working hardly on the Knowledge Hub. We will launch very soon the Knowledge Hub of the THCS, where all the information, all the tools, all the practice as well will be put together. So please stay tuned, because we will send information for the official launch very soon. And stay also tuned for the next opportunities on capacity building. So we have already carried out some interesting webinars, but in September we will launch our Learning Week. For Pillar 2, the pillar dedicated to research and innovation funding, we have launched and funded 3 calls for proposal, 3 joint transformational calls. In 2023, the call was dedicated to health and care of the future. In 2024, it was dedicated to innovate to prevent. And in 2025, which is still under evaluation at the moment, the focus was on strengthening primary care. And of course, Pillar 2 is also hardly working on the framework for project monitoring and also for the project impact assessment. This is an overview of the 3 joint transnational calls. We are today talking more about the JTC 2024, which is dedicated to the prevention. But of course, some prevention projects were also funded in the JTC 2023, and we invite you also to read our impact assessment on our website. The JTC 2024, Innovated to Prevent, was dedicated to the development and uptake of promising health and care organizational models, specifically supporting prevention strategies and their transferability and scalability. Of course, we want the focus always in the partnership is on this transferability of solution and on scale up, because we really wanted to strengthen the health and care ecosystems, starting from what is already existing, so from current practices. And all the projects should, of course, address the opportunities and the challenges for the health and care professionals, and also with a strong emphasis on the appropriate use of IT and digital solutions. The call was focused on secondary, tertiary, and quaternary prevention, but of course, also primary prevention was not forbidden. We had received 114 proposals, and we have awarded 20 projects for 25.3 million euro. We know that some of the projects that have been funded are also online. What we have funded, so the 20 projects funded, what kind of research included in their projects? In terms of prevention strategies, most of them were, working on secondary prevention and tertiary prevention. In terms of research areas, most of the projects were working on health technology research, and some of them also on public health research. And if we look at them, considering their different research types, we see that most of the projects were working on implementation research. That we see from the first presentation from Dr. Carvalho. Implementation research is one of the key points that we still need to, on which we needed to make stronger investments. The 20 awarded proposal that you can, of course, look online. We have a dedicated page on the projects funded, address different diseases, address different settings, address different target population, and try to make the best use of technology and AI. In particular, we have funded projects in the field of aging, cancer, cardiovascular diseases, diabetes, intensive care, 2 projects on maternal health, 3 projects on mental health, 1 project on neuromotor diseases, 2 on orthopedics, and other on other chronic diseases like COPD. They were, of course, addressing different target population, including adult patients, and 2 of them were directly related to young mothers. Older population, in particular projects addressing frailty and aging. We have projects dedicated to pediatric population and on adult population, but with specific focus on vulnerable groups, in particular dedicated to migrants and people with low health literacy. And we had 2 projects dedicated specifically to informal caregivers and health workforce. And of course, as we mentioned also in our strategic research and innovation agenda, projects should also cover different settings. We have projects that are dedicated to activities and practices in hospitals. Most of them are dedicated to care at home using digital solution. Some of them are involved in community care, and some projects are addressing actually all the different sectors in trying to ensure continuity of care. As I said, all the projects address the best use of technology and artificial intelligence. Some of them try to develop new IT tools, starting anyway from current existing practices. But most of them really wanted to leverage results of previous projects, previous IT tools that have been already funded or are already existing. And now what we can do with the synergies. For us, the synergies are extremely important because they help us to overcome common challenges, to avoid duplication and deliver joint results. We need to leverage the results of the partnership and also we wanted to leverage the results of the other initiatives, our sister initiatives, but they are particularly important because we wanted to leverage the results of the project funded by THCS. So we want that really their results are really taken as best practice by and known by other organizations and other healthcare systems different from where they have been developed. And potential synergies with other initiatives are, of course, in the field of communication and dissemination, but it's the very basic type of synergies we can develop. We need the support for brainstorming activities, particularly for the update of the strategic research and innovation agenda, and also to better prepare our joint transnational calls. For us, it's fundamental that you and all the initiatives discover and make the best use of the THCS transferability and implementation framework. We think that we can work together on capacity building activities and also on the knowledge hub that can be really a hub where results and tools can be really available for the research and policymakers community. Of course, all the works done by Work Package 5 on the policymakers toolbox and masterclasses can be also shared with other initiatives. And we know this is an area where some synergies with other initiatives can be particularly relevant. We can work together to define the project impact assessment and to work together for the project results uptake. If you want to discuss all these issues, we are anticipating that our annual conference will be held as pre-conference at UFA conference in November, on the 11th November 2025. So book it in your calendar, and of course follow us on our social and on our website. You can register to receive our newsletter.
Thanks a lot, Laura. I think you touch really well on several things. So not only showcasing what the THCS is doing, what is supporting, but also the fundamental focus on building synergies and especially building on implementation activities and innovation that's already there for the benefit of well, in this case of this goal for prevention. So thanks a lot for this overview. I do not see any specific questions in the chat addressed to you, Laura, but maybe we'll pick up something afterwards in the Q&A. And of course, again, just a reminder, if you want to drop your questions in the chat, feel free to do so. The colleagues are also looking at what you're typing in. But to stay in the nice script that we have, moving ahead to the next project that we're gonna hear from. In this case, we're moving towards how European collaborative initiative can empower policymakers to drive integrated and sustainable health promotion and NCD prevention in Europe. In this case, we have the pleasure to have a double presentation from Professor Knut Klepp, Scientific Coordinator at the Norwegian Institute of Public Health, and his colleague, Dr. Anne-Finn Helleve, Senior Researcher and Work Package Leader within the Joint Action Prevent NCD. So I think, Knut, you're going to start, if I'm not mistaken. So I'll give the floor to you, and we'll perfectly see your slide.
Great, thank you. And thank you very much for inviting us to be part of this webinar. So we're going to present the joint action project called Prevent NCD. And that is a project that, let's see, really aim at reducing the disease burden caused by cancer and other non-communicable diseases in Europe. And we have a strong focus both on personal and societal level, really focusing on primary prevention. We have 4 objectives. One is to improve the joint capacities and also competence within countries and also across sectors, really improve the data and monitoring systems that are in this area. And then we have a very strong focus on reducing social inequalities and reducing health inequity. We heard earlier from Andrea that there are huge differences in Europe between different countries, but we also see within pretty much all countries there are big differences by various social groups, and that's something we aim to contributing to reducing rather than increasing. And then we have an objective of engaging and supporting key actors both across sectors, civil society, and other groups, and enjoy collaborating with other EU-funded initiatives. This is also a large project. As many as 25 countries are participating as competent authorities, and we have more than 100 partners in this consortium. It is also large in terms of the budget, with more than 95 million euros set aside for this 4-year project. As I said, we have a strong focus looking both at societal level interventions and policy and at a personal level. But since non-communicable diseases clearly are the diseases that cause most of the disease burden in Europe, we aim to have a strong population impact. And in order to have a strong population impact, you need to reach large population groups. And often we're looking at small changes at the individual level, but at the aggregate level, when you look at population, it can have a big impact. But when we look at the literature, we see that there tend to be more literature addressing more individual level interventions and policies. We also heard from Andrea that there are relatively few publications addressing prevention, and among those, even fewer looking at implementation. And we also think that there is a need to really strengthen the knowledge base in terms of more population level policies and interventions. And one important reason for that is we think that if we focus too much on the individual level, we actually run the risk of widening inequality rather than contributing to reducing them. And the main reason for that is that it takes a level of motivation, personal resources, and so forth, in order to engage with those more individual level interventions. So when we designed then the joint action on Prevent NCD, we have 6 technical work packages, and they really then try to address the spectrum or the full portfolio of possible policies and interventions that are available. And we have a very strong focus on regulation and taxation as more structural drivers of health and well-being, and on Finn Helleberg will address those more specifically. We have a strong focus on the local community and the different opportunities there are for promoting health and also do prevention work at different arenas within the local community, at the municipality level, at school, within healthcare, but also at workplaces and leisure time. And then we also have a work package on identifying individuals at risk and exploring novel ways of identifying these and also intervening with these high-risk groups. We focus on health and all policies and well-being economy, social inequality, as I said, there's a strong focus, and we then also have a separate work package addressing this across the spectrum of interventions. And then, as I said, the monitoring. One of the reasons why we think it is important to move to the left in this picture is that to the extent you're able then to address underlying determinants of health related to social, economic, commercial, and physical environments, you're really able to address risk factors that are relevant for a number of different diseases. And the further to the right you go here, you end up often having more specific interventions targeting specific diseases, types of cancers, and so forth. So for that reason, again, we have designed our project so that they try to address the full spectrum of different interventions. We are looking at a number of different activities, but we do, of course, also focus on the main risk factors that are well known. We do policy analysis related to tobacco, alcohol, unhealthy diets, and physical inactivity, and do very specific policy analysis and development of interventions, and also trying to scale up successful work. As you can see here, for example, when it comes to unhealthy diets, focusing on reformulation, food procurement, front-of-pack labeling, commercial determinants, in particular marketing of unhealthy items. And we also work a lot then at the local community in setting-based interventions, as I said, at municipality level, schools, workplaces, and also in healthcare setting, including breastfeeding promotion. So this was kind of the general intro, and now I will give the word to my colleague on Finn Helleberg, who will then talk more about the policies. Thank you.
For this smooth transition, so let me just see. Yeah, so I'm leading the work package 5 then, and I will just say more about the prevention aspect of fiscal and regulatory policies. The first thing I just wanted to show is that when we talk about prevention within public policy making, it's important to understand how policy decision-making processes take place. And this is a very schematic presentation of it. There are other ways that can be presented as well, but But to understand the policy process, it's important to acknowledge there are different paths. And just an illustration for the activities that we have in our project, we have activities both in the left and to the right in this arrow. We do, for instance, we analyze policy needs. With the example here is the extent of digital marketing, for instance, for alcohol and unhealthy foods. But we also do explore policy options. A very concrete example is the possible introduction of alcohol warning labels in the EU, but also in the member states. But we also want to look at whether the already decided policies are being implemented and to what extent they are being implemented. And the example here is the use of nutrient profile models, but also to show the differences in policy, that there are policy inconsistency between countries. This is also kind of a follow-up link with what André Carvello from IARC just mentioned about country differences. We also know that there are many policy differences between the different countries. And finally, we also do assess and model policy impact, for instance, of health taxation, because health taxation is a measure that is difficult to kind of evaluate in a traditional experiment. But the way of modeling it could be a way to demonstrate the potential. But also another thing with regard to policy decision-making process is for us that is working within public health also to understand that although we think that it should be evidence that is guiding this policy decision-making, we want it to be evidence-based. Maybe we should be happy if it's evidence-informed, and we think that the health is the kind of the key aspect here. But I think we have to acknowledge that the policy decision-making process is much more than evidence. You have interest, values, public opinion, and public discourse, and of course there are other policy areas other than health that are also policy decision makers are related to. So, for instance, in this period of time, security is an example of a policy area that is kind of on the top of agenda for many countries and at the EU. So for one of the key approaches for us is to kind of try to support member states in the use of fiscal and regulatory policy measures, because they are population based, as Knut mentioned, but also understand this in the context of policy decision making, implementation, and not at least enforcement mechanism. And then, as I said, we have to then acknowledge that this is about political priorities and trade-off. And it's also important that we are able to provide kind of documentation with regard to the proportionality of the measures, that we can demonstrate the necessity and suitability of the measures. But there are then, of course, as I described, it's quite complex, the whole process of policy decision making, both the links with values and ideology. For instance, the example of claiming that if the regulatory measures are too strong, it will be an end state, but also because of there are other forces that are kind of lobby against effective measures. So, and on top of that, it's not only about influencing behaviors and prevalence of disease and cancer, but the whole array of policy decision making is. We have so many policy levels within Europe, and we have different policy areas. So it's important to not to make this too complicated, but I think again it's important to understand that there are so many policies out there that can be taken in place. But it's about the policy process, but also the different policy level. For instance, the example of fiscal activity, maybe the most important policies can be done at the municipality level, but while health taxation will be on a higher level. So it's important to understand that this policy decision-making process is complicated. So one of the things that we are supporting in the project is to try to look into policy monitoring, because as it's been demonstrated by many sectors, we know that there are huge differences between countries in terms of policy implementation. This is an example from WHO Empower system, but it just illustrates that there are within the policy areas that they have defined, there are huge differences. And there are many examples of databases of these policies monitoring, which communicate the same message, that there are differences between countries in terms of implementing already known policies, but has not been taken into place. So for us then, kind of the key message we want to communicate is that we all know that there is no single cause for cancer and NCDs. of that reason, there will not be a single solution either. But it's important then to also acknowledge the link with policy context and the sum of policies, and to understand that these measures are political. So to conclude, then, this is meant as a conclusion for both Knut-Inge and my presentation, that we argue then that population-based policy measures are needed to have a significant impact on the large and preventable diseases in Europe, and that we, as a project, then set out to implement and evaluate and scale up legislative, physical, and pedagogical measures. And it's important to acknowledge the link between structural measures and public policy making, and that cross-country comparison and collaborations are valuable and necessary. Thank you. This is just a contact info.
Thanks a lot. Thanks a lot to both colleagues from Norway for the very good and overarching presentation on the work of the joint action, which is well, particularly interesting because it's looking at indeed many different things, as it was rightfully said. It's not a single cause. It's a very complex and diverse environment we're working on when it's about prevention. So thanks a lot for sharing what you're doing. And maybe as I see a question to Knut actually in the chat, I'll take the chance to ask it directly as I see it back in the little box here on Teams. So a question from a colleague: if you have mapped if and how SDH are being embedded into personalized cancer prevention policies in your countries, is this something that you'll be looking at, Knut?
Thank you. We're using a lot of abbreviation in our field. So can you just remind me what SDH is short for?
I would suppose are health determinants.
Social health determinants.
Yeah, exactly.
Yes, thank you. So yes, in the one work package where we are focusing on identifying individuals at risk, we really are trying to map up and do systematic reviews. I can't recall exactly what stage that is in, but this is something we are looking at within that work package. Thank you.
Thanks a lot. And maybe, well, right on time, just another question still for you from Dorian. If you also focus on the role of industries such as tobacco on policies, I think it's something that was briefly teased out. So back to you.
Yes, thank you. Yes, we do have a keen eye on what is now called the commercial determinants of health. So both when it comes to tobacco, the tobacco industry, but also alcohol and food industry, we try to really analyze and see what kind of strategies are they using? How can we empower decision makers to understand and recognize those strategies, and what would be good measures to meet them? And we also collaborate strongly with the WHO and other actors in that area. Thanks.
Thanks a lot. So indeed, you've also covered a couple of specific things that emerge from our audience, and well, right on time, maybe, as we're still very much in your dedicated slot. An extra question on One Health. Are you looking at that when it comes to nutrition, for instance?
We don't have specific activities as such, but of course we acknowledge the context that the One Health agenda is creating. So we are definitely working within that, but we don't have specific activities addressing animal health, for example.
Thanks a lot. Indeed, colleagues from the audience, feel free to keep posting your questions. We're going to pick them up also later in the Q&A, which I very much believe we're going to have time to run through. But before that, I would still like to go to the last but not least presentation of today. Now we're going to focus on the JANE2 joint action. So in this case, I think I'm going to be the colleague from the coordination team to post the slides. And we have the pleasure of listening to Delia Nicoer from the Oncology Institute in Cluj-Napoca and leader within the joint action JANE2 of Work Package 8. And Delia, if I'm not mistaken, you're going to focus on how the newly established network of expertise is working to strengthen personalized cancer prevention. So Delia, the floor is yours, and I believe your slides will be also up very, very soon.
Perfect. Thank you so much, Michele. Can you hear me well? Can you see me? Everything is fine. Perfect. And thank you, Laura, and thank you to everyone for this initiative. I think it's very important because we have so many prevention projects. And if we are going to do synergies, I think we should start from the beginning with these synergies. We are only 6 months in JANE2, so we are still figuring out how this actually new network of expertise will function. We can go to the next slide. JANE2 is a joint action. It's an European initiative. I think it's one of the biggest projects in terms of the number of the partners involved. We are 121 partners. This will be happening over the next 4 years. We are trying to develop 7 new networks of expertise with participants in 29 European countries. If we go to the next slide, please, you can see here all the 7 new networks of expertise in the field of cancer, complex and poor prognosis, palliative care, survivorship, omics, high-tech medical resources, and adolescents and young adults, and of course, Work Package 8, or the new network of expertise on personalized primary and secondary cancer prevention, where we are together with Italy, with Stefania Boccia and her team coordinating this network of expertise. What's the goal here? And I will come back to the title of today's webinar, the Synergies. We were looking into JANE1 at the definition that Prophet provided to us in terms of what personalized prevention means, and we tailored it only to oncology or to cancer. What we learned is the fact that we need to integrate environmental, genetic, and lifestyle factors in order for us to create this new network of expertise. Now, the biggest objectives for the network will be to integrate education, policy, twinning activities, which I will explain a little bit later what that means, and innovative tools. Into the next slide, if we can go, please. Now, we have 10 different tasks for the new network of expertise on personalized prevention. We have 6 core tasks and we have 4 transversal tasks. So beginning with the core tasks, or the tasks that we are relying on, and starting with education, as we all know, oncology is not an easy one for the young doctors or for all the physicians. So what we saw in the last years in Europe, in all member states, is the fact that fewer and fewer resident doctors or physicians are choosing cancer-related specialties. So that would mean that the current physician would have to learn about personalized prevention recommendations or strategies as well. So that's why we have education, training, and health literacy to improve the knowledge base of the healthcare professionals, but not just for the physician, also for the nurses. You cannot really develop a new network or a new framework or blueprint for personalized prevention without adding or including the policies at European level or at member state level. That's why we have the health policy task, where we want to develop health policies to promote the adoption of personalized prevention, but also using AI, because this is something that it will be in a continuous growth for sure. Now, the third task on the lifestyle aspect, we want to identify the lifestyle factors that contribute to cancer risk by to risk using the exposome paradigm. Of course, we are only 6 months into the project, so we will be very happy to share with you once we have the results for these two tasks, for all of the tasks actually. We have another important task to map the personalized initiatives and also to identify the omics-based strategy and to assess their cost utility in prevention, and together with the genetic and epigenetic risk to explore the clinical application in cancer prevention. So we have all these tasks, but what are we doing? We are only collecting this knowledge, or do we use this knowledge by sharing it to the physicians, to the people that are actually working into public health institutes or hospitals? We can go to the next slide, please. And you can see here the transversal task forces, or the tasks that are helping basically all the other tasks by disseminating what their findings are from the core tasks, to share the activities to the relevant stakeholders, to the politicians, to the general public, and sharing it with cancer patient NGO as well. We have the evaluation one to monitor and evaluate the progress of this network of expertise, the governance. Now, this one is a tricky one because you have a network of expertise. We don't know if we will become a legal entity or not, but you need to work to function based on a framework. So that's why we have the governance task to establish the most efficient mechanism to coordinate this network in collaboration with all the other stakeholders that we need to be part of this. Sustainability, I think it's the most difficult for us, at least in the first stages of the project, because you need to ensure long-term sustainability of the network. After these 4 years, we would have to have a strategy on how this network will function by its own. Integrating synergies with EUNet CCC, it's another big joint action, European Network of Comprehensive Cancer Centers, where we have the personalized prevention primary and secondary aspect, but integrated into the hospital, integrated into the comprehensive cancer centers. So that's where we have collaborations between JN2 and EUNet CCC, so we can establish from the start the synergies that we were talking about. And because Europe, it's not actually the best in terms of prevention, we search for partners outside Europe, like Australia and Canada, to establish international partnerships with those countries in order for us to grow a little bit faster and maybe better the prevention strategies. Next slide, please. Now, as any other project you would expect, we have some deliverables, the recommendations for personalized prevention, screening, and also the twinning. What is the twinning means? That means that we will be collaborating with a hospital or a public health institute will collaborate with another hospital from another country where you have probably a similar healthcare system, so you can create partnerships and maybe find the best prevention and screening strategies that you can use for your country. For example, in Romania, I think it was unfortunately given as a bad example in terms of the prevention that we use in the country, and we learned a lot in this last year what we should do to improve it. Actually, we saw that one of the best countries that we can copy the prevention strategies is France, because we have a similar healthcare system, so we can just adapt them to Romanian healthcare system. We can go to the next slide. Now, these are what you heard so far. This is what the Network on Personalized Prevention is aiming to do, to connect the experts for prevention and screening, to help, and I think this will be a great synergy with Prevent NCD as well, in terms of the health policy, create the health literacy education programs together with EUNet CCC to deliver afterwards to the physicians and to the nurses, and to integrate the omics, environmental and lifestyle factors in order for us to create afterwards the recommendations that will be shared with the stakeholders. We can go to the next slide, please. In terms of research, you saw the task 8.4 and 8.5. They aim to explore the omics, polygenetic risk scores, and lifestyle factors in personalized prevention. Our goal is to go into more depth analysis of the clinical utility, feasibility of these innovative approaches, and to emphasize on generating clinically relevant and applicable evidence. To the next one, after research, we have, next slide, please. We have education. We already started with the mapping of the existing educational initiatives in cancer prevention, and to help to enhance the healthcare providers' knowledge on these strategies. And to align, of course, with all the other projects, and starting with the projects that we heard about today. Next slide, please. We have the policy. We are aiming to conduct interviews with the policymakers, because this is a new it's a new subject. Precise prevention is something that's only been talked about in the last few years in Europe. We have the chance of synergizing or having a unified strategy for all member states, and we can have this unified strategy from the start, and we don't have the need to align afterwards with every member state strategies. So this is our goal for the policy. We can go to the next slide, please. And this will be our recommendations that we want to have by the end of the of this adventure of the 4-year project, to promote this integration of primary and secondary personalized prevention as a standard in healthcare delivery, and to help introduce a bumper app or another risk calculator in providing more precise and specific prevention services to the caregivers or to the family members of the cancer patients, and to recognize risk calculators as effective clinical decision support tools for healthcare specialists as well. We can go to the next slide. Of course, we are not alone in this project. We have partners, professional societies, NGOs, and organizations as IARC. We are waiting, of course, for the updated, the 5th version of the European Code Against Cancer, to see what are the changes and how we will not change, but adapt the course of our work in this network of expertise. Professional societies at ESMO, ESTRO, and ESO, or ECL, OECI, or European Cancer Organization as well. We can go to the next slide, and I think it's the final one. Why is this important? I think it's amazing that you started having this type of webinars. We need this type of initiatives in order for us to connect and to not have overlaps between our work in different prevention-related projects. We are providing the networks, being the network of expertise. We are collecting all the experts and providing you the experts for this network. And I think together we can have a shared vision for a better, let's say, Europe in terms of personalized prevention. Thank you so much again to the organizers, and if you have any questions, please.
Thanks a lot, Delia, also to you for this overview on Jane too. And indeed, there are actually some questions addressed to you in the chat, which I would like to pick up. One first question is, I believe there are several healthcare professionals that are targeted basically by the activities of Jane2 in the audience. So, well, first, maybe a very direct question: how can they join the expert network? How they should stay in touch with you? And second questions, if you have a specific activities network for rare disease cancer.
So to answer to the first question, I think I will answer with another question. You can tell us in which institution are you currently working, so we can verify if you are already into the network, because you saw that we have 121 partners. So if you are already into the network, then it's very easy. You can just send an email to us, and we will be adding you to the mailing list, and you can participate to Work Package 8 meetings. If you are not in one of the cancer centers or one of the affiliated entities or competent authorities that are already into the Jane2 project, then we would have to see how we can add you to the network, talking with the coordination team, of course. And rare disease, no, Huracan is the network that's actually in charge of the rare disease, rare cancers. And this is why Jane2 actually wanted to create another other networks of expertise, but focused on different subjects that other than the rare cancers. So that's why we have a prevention one, because it's one of the biggest topics and one of the most difficult ones, because we have different healthcare system. We have 27 different EU member states and the rest of the associated countries to the EU and Europe, and it's not that easy to find the perfect strategies in order for us to make them work in the other countries.
Thanks a lot, Delia. And I see that the colleague also mentioned that the organization is working with in the chat. So I know that that you also shared your details in the slides, if I'm not mistaken. So I believe there will be the chance for people to of course reach out to you and connect directly. So I would like.
Please, you can write to me or to Stefania, and we can see, if you are not already into Jane2, how we can add you into the joint action, and then specifically into the prevention network expertise.
Perfect. Thanks. Thanks a lot. And indeed, I believe other colleagues are also adding few extra questions and responses to the comments. So we are well now heading essentially to the last part, the discussion and closing remark. Before checking if someone has some additional questions, and I do maybe have some extra ones that I would like to ask to the different speakers. I also know that there are several colleagues from the European Commission that are following the different initiatives that were presented here today. So this is just a generic welcoming message to them if they want to come in and provide some additional remarks. But in the meantime, maybe what I would like to ask to the different speakers as a kickoff questions. I mean, today was also about synergies. It was like indeed a very important occasion to start connecting between this joint action, although I understand already that several of you are doing it already and are very much cross coordinating between the different actions. Maybe a general additional point is how projects that are maybe funded to Cancer Mission or other programs that are tackling some elements like primary prevention, for instance, can get in touch with you. Do you have any plan for, let's say, going to create synergies beyond the 4 projects that we hear today. I don't know if some of the colleagues would like to take that. Maybe Knut, yeah.
Yeah, thank you. And again, thank you for this initiative. And it is great to getting to know this other project better. We are collaborating quite a bit with Yacardi, which is a large joint action focusing on cardiovascular disease and diabetes, and also on mental health, and then a number of other more specific cancer-related joint action on registries and other aspects, and very much value that collaboration. I noticed that a couple of the projects are going to present in Helsinki and at the European Public Health Conference, and we are also planning both pre-conference the day before and have submitted a large number of workshops to the main conference. So maybe that can be a good occasion for several of us to meet and discuss more in detail as well. Thanks.
Thanks a lot. Very good point. And I see Delia wants to come in on this as well.
Yeah, we are collaborating with EU NetCDC, mentioned in the presentation. I think another one that we should be, I think, more in contact would be with Prevent NCD. So I'm happy that we got to know each other in this webinar. Of course, we are collaborating with Prophet because we have the common coordination team in both projects, and EUCAN screen as well. We will have the meeting in a couple of days in Turin.
That's great. So indeed, I think this was one of the important elements of today's meeting, creating even more connections compared to the ones that are already there. And maybe Laura wants to add something to this.
I mean, for THS, I mean, the synergies are fundamental at every level because, of course, there are different initiatives that have different dimension. We are trying to combine and take from different projects what they can really provide to the overall research community and all the policymaker and health professionals. And of course, projects that are producing results are invited to contact us. As I said, we will launch very soon the Knowledge Hub, and for us it will be, I would say, a cornerstone because we really want that all the results from projects that are relevant for the transformation of health and care systems are stored there. One of the advantages that we have is the duration of the partnership that we hope will also last after the 7-year duration. But anyway, all our all the funding agencies that are working on in the partnership are of course committed in the topic, and we really wanted to create a system that is sustainable in the long term, where all the resources produced not only by us but also from others can really be available for all the community.
That's great, Laura. And indeed, I think this is important because, of course, the joint action and initiatives of this scale are fundamental. But indeed, I understand, as we also part of some projects, that there are other clustering initiatives under, for instance, Cancer Mission that are indeed looking at elements on implementation, research, and prevention. We are part, for instance, of a project called OncoDear that is looking at primary prevention for colorectal cancer. So, of course, it's very hard indeed to take into consideration all the different specific projects that are looking maybe in a disease area. But I think by initiatives like this one, it can clarify even further who's working on what in this arena and create those connections. Just trying to see if there are questions from the audience, but if there's nothing new, I would actually like to pick up one. Oh, okay, there you go. Well, we have one question on nutrition. I think was touched in several ways by several projects. So as part of one of the most important prevention strategies and the need, of course, to rethink, redesign how food is produced, transport, and so on. So just open questions to all the speakers. Is there any part of your project that is specifically collaborating with this aspect in mind? And maybe if there are other people in the audience, feel free to drop some ideas in the chat as well. So nutrition and collaboration, any of the projects that we have today are specifically looking at that? Knut?
Yes, thank you. Within JA Prevent NCD, we are looking at aspects of it, not all of it. We don't look directly at food production, but we do look at reformulation to make food more healthy, and again, collaborating with WHO and others to see to look at the way of categorizing different foods. And we also are looking at procurement as a very important aspect. We see that both municipalities, for example, are one of the largest procurer of food, and they can set criteria that could have implication then for food production and transportation and so forth. So those are some of the aspects we are looking at, and this is also within Arnfinn Helleve's work package, and he might want to add some to it.
Oh, I was so very happy that you remember, because I was thinking that it was a hard one to answer. But, yeah, so it's true, but I don't think that we don't get, for instance, the food production in the self-transportation and storage, for instance. I don't think that we have any activities related to that, but it's correct that you say that food procurement and food reformulation is one of the important tasks within our work package.
Thanks a lot. Any other projects, Stefania, maybe, and then Laura?
Thank you, Michele. Yes, not really in profit, but in another project that was a Maris Lodowska Curie project that finished just a few months ago. We basically made a mapping review of all the trials that were aimed at understanding whether people change behavior, including also nutrition behavior, based on the knowledge of their genomic background. So we mapped all the trials that tested the hypothesis whether people change behavior, including lifestyle behavior and nutrition, based on the knowledge of their genomic concept. Results are not very much encouraging. So people like change behavior in the short term, but then go back to the usual lifestyle habits. But it's very interesting, I mean, to read the different aspects of the study, also the different points used. So it's very difficult to compare the studies collected. So hopefully it will be published in the coming months. So it's not about policy, okay? It's about primary evidence from trial about how people can change behaviors based on a personalized preventive approach based on their genomic background.
Thanks a lot, Stefania. Laura?
I'm just picking up this question as an opportunity to say that actually we really need to move from probably the comfort zone when we talk about strategy, because of course, I mean, it's not easy, but it's quite immediate to create strategies with initiatives that are similar to us. So for THS, of course, it's streamlined to work with other partnership. We are trying really to get in touch with the joint actions, because for us, it's even if it's different funding program, but they are really, really relevant initiative. But maybe we need really to work also with the initiatives that are outside the health cluster. So I know that there are initiatives working on the food production, and we really need to make an effort to work with others.
Thanks, Laura. Indeed, that's a good point, and I think it emerged also from the example that Knut and Arfin were mentioning about the importance of procurement, for instance. So, going beyond the health specific and health focus to see what other policies can have an impact in health. We've been talking for years about the concept of all policies for health, but also I think looking at the health in all policies, it's equally important and it's equally fundamental for prevention, where we've seen that anyway, budgets are yet and still quite scarce. But Arfin, maybe you want to add something.
Yes, I just want to add on this comment on the thing, and you also mentioned this term health and health policy and the importance of other sectors. I think that maybe one of the challenges has been that we from the health sector are trying to convince the other sectors that they have to do this and that because it's relevant to health. But perhaps it's also important in the argumentation to argue for their co-benefits, so that they can kind of fulfill their ambitions in their sector, not necessarily on health, but for instance in food production or I don't know, consumption. So I think that there's also something to look in there, how we can interact with other sectors without always using the words of health instead of look in their own terms.
Well, that's a good point, and actually I think it brings back to some of the keywords that Andrea at the very beginning of today's session was mentioning, indeed, on how we communicate, with the other stakeholders beyond, let's say, our circle of collaboration, which is really important, but maybe it's just a piece of the cake that we need to advance on prevention, as on many other things related to health. So that's very good. I see that there's a very good exchanges actually in the chat still. Maybe a question indeed that I see now here just popping up on my screen. Well, very nice. Thanking you all, of course, for the presentation. But maybe a question that I don't know if it fits directly in the projects that we've heard today, but if there's anyone researching genetic background for susceptibility to medical side effects in cancer treatment, chemotherapy drugs in the health population. Again, maybe not much on prevention, but Stefania, I saw that you raised your hand.
Yes, thank you, Michele. In the context of project, the second case study of the use of health impact assessment was about a pharmacogenetic passport. It was a case study about the impact of the health of the population of the current use of pharmacogenetic passport, which is a reality in some European countries, especially the Netherlands. Okay, I think this is the only one. Maybe Spain is doing something. It's a case study about the health impact of pharmacogenetic passport, which is not about only cancer, okay? Not only population level to be used to prevent adverse drug reaction in cancer treatment, but overall in any treatment. And results are very much encouraging. And so if you want to know more about this work about pharmacogenetic, it's a policy, evaluation, okay? It's an health impact assessment, in fact. If you want to know more, because we are in the middle of drafting a paper, because the deliverable is on the website, but it's not public, unfortunately, not yet. If you want to know more, just send me an email. I will be happy, Elena, to talk to you about that.
Thanks a lot, Stefania, and saying also, I think that's an important point made by colleagues in the chat again. When it comes to meeting with unusual partners, I think there are initiatives that try to do that in the past, like the European Innovative Partnership on Active and Healthy Aging, which is also something that I believe the THCS fairly built on from to reach and beyond. So indeed, also as we're heading towards the last few minutes, I think another key points that I took from today. Well, one thing is synergies before existing project, but I think it's also synergies with what's existing there already. It's been implemented for years. I know indeed the THS. It's one of the key elements of it, but I've also come to understand that it's very important for all the other projects. As well, I see that of course prevention, as it was discussed here, is of course a very important policy objective, but it's also very much a matter of collaboration between different actors in the healthcare sector and beyond the healthcare sector. So that's maybe one important takeaway that I will get from this meeting. We still have very few minutes before ending in perfect time. I maybe want to just pick up one question that I've spotted at the very beginning of the discussion coming up in the chat, and that's maybe open to everyone on how this learning between cross-country, which is what all initiatives that we've heard today are taking into account different cultural aspects. Is this something that you're looking at that, or is this something that just emerged in your discussion? And maybe linked to that, another important question that I've seen being answered already. We've heard that several of the projects are collaborating directly with patient organization, like EPF, Active Citizenship Network. But if the others also wants to mention something quickly about how they collaborate with the patient level, happy to hear. So maybe Delia wants to kick off this final round.
I can answer to the first part of the question. It is a very good question and a very tricky and difficult one, because we started working on this by consulting the country profiles provided by the European Commission. So from the country profiles, we were looking at the prevention and screening strategies and trying to see what healthcare systems will be the ones that can be the most, let's say, close in terms of structure. So that's why we have more twinning between Romania and France, because we have similar healthcare systems, so we can copy quickly what is going on over there. In terms of cultural aspects, I think it will be the next step and probably a useful one to look into.
Thanks a lot, Delia. And Knut, maybe you want to add something to these things, and Laura.
Yeah, a quick comment to your second part about the collaboration with patient group. In fact, we don't focus so much on patients as we do on the general population, but we have a lot of experience then in mobilizing and engaging with end users. So, for example, youth, we have a separate youth advisory group on our project. We work a lot with decision makers at different levels, and we have a so-called policy decision maker forum. And we do engage with decision makers at the different levels throughout the consortium. So we have quite a bit of experience on how to work with different population groups, also other than patient groups. Thanks.
Thanks a lot. And Laura?
Just to say that the differences among countries, health and care systems, also differences among regions, is actually the starting point of the European Partnership on Transforming Health and Care Systems, because we started thinking that when a good practice is good somewhere, maybe it's not good somewhere else. And so this is why I highlighted very much the effort that we have done to create the framework for the transferability of practices. And we hope that it can really be an added value for different projects and different initiatives, because we can support the transferability and scalability of practices to ensure that when the practices is good somewhere, can really become good also somewhere else. And we don't really need to reinvent the wheel, as someone said in the chat.
Thanks a lot, Laura. And I think we can close today's meeting. I would like to thank all the initiatives that joined the forces today for giving me the chance to moderate this. I've learned a lot, but also at the same time, I've heard many important things for our work at Euriga and beyond. So I know that indeed the meeting has been recorded, that the slides will be shared soon. So I think all participants will receive those. Other than that, I would just like to thank all the speakers that were here today and the various colleagues that helped in coordinating this very nice joint workshop. Other than that, I wish you all a pleasant rest of the day and of the week, and a great month of May. Thanks a lot, everyone.
Thank you. Bye-bye.
Fermo la registrazione.